May I invite Dr. Bala Bhaskar and the panelists to come on to the stage. Dr. Anjan Trikha, Dr. Sudhakar Koppad, Dr. Anju Grewal, Dr. Rajani Sundar and Dr. Wayne Morris. And we would run the session for 30 minutes, and the questions which are not answered we have had a great response, and the questions which are not answered will all be mailed to you. And also we have selected the 3 best questions, and they will get the prizes. Over to Dr. Bala Bhaskar.
Thanks a lot. Thank you, Dr. Bala Venkat. A very new initiative again. But I must admit it won't be strictly open forum, because we thought of the time constraints. If I have totally open forum, there could be some sort of disorderliness. So we used social media. We requested all our delegates to post some questions to us. So we have about 10 questions which are selected out of them. And we have got the 5 faculty here. And we have distributed the questions among the 5, and each one, as a specialist, will respond. So we had at least about 80 to 90 questions coming to us. Some of them were very good. Some of them, I don't know whether our colleagues will be able to answer also. Very difficult to get in the literature, but they have come prepared. Probably this is... they will try their level best, and there won't be something like this. We'll try to go in an orderly fashion. No noise at all. Okay? So thanks a lot. We will begin with Dr. Anjan Trikha here. I have picked up some basic questions which I keep on hearing everywhere I go. And something which are unusual, and something which are latest also, which are just come in the publications. The first question would be taken by Dr. Anjan. The question is by Dr. Jesto Kurian. I can just get the delegate here. Yeah, he is there. So the question is here for all of you to see. So can we repeat spinal after partial action? So I have just pasted just the way I have received from these delegates. So what it means is, after giving spinal anesthesia, can we repeat anesthesia again? A few hours later, few days later.
Yes, I think you can repeat it, few minutes later, once you are sure that it's not working or it has not worked, and you are duly prepared, and there's an indication to repeat it. You should be very clear that I add the second one again, along with it, that the dose goes down by 15 to 20%, but every time I have done that, I have lined up with some appreciable amount of hypotension. So you should be mentally prepared to take care of that. So the answer is yes, the dose has to be reduced by about 20%, 15 to 20. Should I go on answering these?
Yes, sir, please.
Yeah, okay. And the dose of the drug after waiting 10 to 15 minutes. What my problem is that a lot depends upon what kind of case you're doing. The most of the times when it becomes essential that you give a repeated spinal, you either are doing a cesarean or you're doing a difficult spine or a spine with deformity. These are the most common places where I've lined up into a fix and I need to give a second spinal. So the indication is there to give a spinal, and you waited for 15 minutes, but at the end of 15 minutes I would surely want to know whether it's working or it's not working, or it's a partial spinal. It becomes important. And then I want to know whether I am the best possible person to give a repeat spinal, or I could call Dr. Morris, who is a much more expert than me, to give a repeat spinal. That's second important thing. And then the thing which comes is, do I go to the same place or I go a space higher? That's important. Because when a final is partial or it fails, the person who's given a spinal is very sure. He says that at least 5 ml of CSF came out and it never worked. Yes, that's the way people speak. In spite of that, spinals fail. So there could be a local problem inside, an anatomical problem. So I normally go a space above. A different pair of hands, cooler head, a space higher, decrease the dose. Prepare for hypertension, which will be needed to be treated emphatically and promptly. Then we come to the next one. How many times respinal can be given in a single setting? Well, there are no guidelines. The max, if you come across the literature, you give it twice. But if you fail, the next one also fails, then it's very unlikely that you would be giving a third spinal in the same sitting. You'll have to go to your plan B. What I have realized in my practice, and I've changed, from time one, if I'm going to be a bit of an issue, I give a C needle to needle, then a single spinal repeated, and then again fail. Okay, that's the way I do, but that is beyond this question. But the literature says that you give about max 2. I've never gone to 3, and I'm not aware of any literature which says that you go up till 5 or 6 or something. We come to the next one. No guidelines for any surgery done after a few hours and days. That's fine, because you could do surgeries with continuous spinal. We have done that. Angst spondylitis patients, tough ones which you come, we have normally seen that if you by mistake do dural puncture, the easiest way is you thread the catheter in the dura and get away with it. So you can give your repeat spinal after few hours or days. That's not an issue. But you have to be aware of the indications of doing it, and you should be well prepared to manage the complications.
Thanks a lot. So we, because of shortage of time, I initially thought I can take opinion from our co-faculty in addition, but I have selected about 10 questions. So what we will do is try to finish these 10 questions. Okay, if I got more time, probably we'll have more exchanges. The next question would be to Dr. Anju Grewal. The delegate who is sent the question is Sonu Balsara. Yes, madam. So what's the role of sphenopalatine block in control of PDPH? How is it performed?
Yeah, actually, personally, I do not have any experience of putting in sphenopalatine blocks for PDPH or for otherwise. But when I searched the literature, what I found is that basically it works on the principle that whenever there is a PDPH secondary to a dural hole, there is a loss of CSF volume, and a reflex cerebral vasodilatation occurs as a result of that to compensate for that volume. And therefore, a sphenopalatine block works because there are parasympathetic fibers that are synapsing up there, and you're blocking those fibers, and this cerebral vasodilatation, which has occurred reflexly as a compensatory mechanism, is basically blocked by these blocking the parasympathetic.
Yes.
So I happened to open this article as well in the afternoon.
Yeah.
And then that's how this works. But a word of caution here: all that has been described in literature are just anecdotal case reports or case series. There are no randomized controlled trials or no observational studies as of now to justify its superiority over epidural blood patch or other measures. So we still have a long way to go till we actually declare this as a modality of choice. Okay. But of course it can be tried. The way to put it is quite simple. That is the reason it has gained popularity, is that you just put long pledgets parallel to the floor and reach when you meet resistance. Basically you will need to position these pledgets, which are soaked with xylocaine, into the between the superior and the inferior turbinates, and leave them there for some 10-15 minutes. I think that's how this this block works.
Yeah. So you can see that illustration. The point where it's ending around the middle turbinate is soak it in ointment or even a solution, either lignocaine or sensorcaine. Both of them work. I got it done in one case and it has worked. Very one isolated case, but I cannot vouch for its actual effect. Thank you very much, madam. This is to Dr. Wayne Morris. Very tricky question here by Renu from Kottayam. Tricky question. She is here. Okay, in absentia. So does it make sense in adding the surgeon's skill in the risk stratification and morbidity and mortality of a patient?
I think this is a very interesting question, and I'm glad I had some time to prepare an answer. I would not like to have seen this question without warning. I think when we're talking about risk stratification before surgery, there are some tools that we're very familiar with, like the ASA physical status score, and one that our registrars are using quite a lot is the P-POSSUM score. So there are these formal tools. So I'm taking this question to mean, should we formally add in surgical skill into these scores? And I'd like to just get a show of hands in the audience before I answer any more. Who would like to see some sort of measure of surgeon skill in a risk stratification tool?
Both hands. High tensity.
Okay, well, I think the next question is, if, especially for those who think there should be a surgical skill part to the score, who thinks there should be an anesthesiologist skill assessment in the risk stratification tool? Okay, at least you're consistent. Very good. I guess my own personal answer is I would have some difficulty with adding in a formal assessment of either surgical or anaesthetic skill into a tool like this. And part of the problem with a lot of these measures is the subjective nature of them. But I think what we do is we tend to informally consider things like the surgeon's risk, surgeon's skill, and also our own skill when we're talking to the patient about perioperative risk. So while it's not formally part of a tool, we are thinking, is this surgeon any good at this? And that will affect the way that we talk about the risk to the patient. And I think what we do also as anesthesiologists is, with time, our skills and our knowledge change as we do different operations, and if we're honest with the patient too, we include our own knowledge skills when we're talking to the patients about perioperative risk. So the short answer to the question from me is I don't think we should be doing this formally, but I think we do it informally all the time.
So I think we should not be expecting something like this to happen, because we are also at the other end. So just for the sake of discussion, that should end there. Thank you very much. Now to Dr. Sudhakar Koppad. A small little revisit, because this concept has been known for last few years. Is pre-op enteral acetazolamide effective in decreasing shoulder pain after laparoscopic surgeries? By Dr. Jesto again. Yeah.
The shoulder pain after laparoscopic procedures, be it any pelvic or abdominal, which often appears immediate post-op period and lasts for at least 2 or 3 days. Very many times it is worse than the surgical site pain. And also the incidence, perhaps in our own practice, I see 20 to about 60% of our patients continues to baffle both clinicians and researchers. Based on, again, our own experience and also the recent published study in anesthesia and pain medicine, clearly with huge randomized study, acetazolamide given in the dosage of about 250 to 300 milligrams an hour prior to laparoscopic procedure has not been very effective in decreasing the pain. In fact, some studies also reveal it has added to the pain rather than reducing, for the reason it has enhanced in decreasing the pH and causing peritoneal acidity. So that is the answer to the first question. To corroborate this, the Cochrane database review in last 10 years, reviewing very many published literatures, they endorsed this by suggesting laparoscopic shoulder-related pain has also occurred when carbon dioxide was not used, when other gases were used, and also when no gases at all were used. So this endorses the theory, the relation between the carbonic acid, the reduced pH, diaphragmatic irritation, and subsequent shoulder pain. Well, coming to the next question, what are the strategies? Of course, Cochrane study further continues to suggest as acetazolamide related thing, carbonic acid could be the one of the reason, but there are very many other precipitous causes. Perhaps the surgeon's skill, as we have been talking, anesthetist skill too, the pressures of insuflating gas. If we are using dry cooling effect of the gas, and also they talk about the tethering effect of coronary and triangular ligament of the liver. These are the few things which have been the possible cause. But most important thing which notably I noticed was the diaphragmatic neuropraxia, which I like to highlight in next few moments. Due to the unwanted abdominal distension which leads to expansion of the peritoneal cavity, also the diaphragm, the phrenic nerves fibers in the diaphragm, they go into neuropraxia. Perhaps this could be the reason. So, answer to the strategies, apart from what we have been using already, epidural, stab block, chordatus lumborum, peritoneal instillation of local analgesics and saline, postural things, they have not given consistent results in preventing this. But what, being a regional anesthesia enthusiast, which I like to add, possibly, preemptively, can I consider blocking selective C4 route, which is a dominant phrenic nerve contributor? Perhaps some of us who can take up this, we can add to this, which may help our patients in decreasing this.
Yes, sir. It's a good suggestion, but we should think about the pros and cons, how invasive and whether you want to do by route, which route and which aspect. But anyway, as you said, we have some publications which are restricted. Immediate post-op period only there has been some sort of relief. And subsequently, at the end of 2nd hour, 6th hour, it was never there. Next question is to Dr. Rajani Sundar here. It's mainly related to the pediatric practice. Question by Dr. Kiran Chand. Subarachnoid block and caudal epidural administered in the same sitting for the same procedure, like caudal being administered followed by spinal in pediatric patients, with the dose of local anesthetics administered within the recommended upper limit. Is it okay? We have some guidelines here, madam.
I could not find any guidelines for this. Only few references I could get. Most of the time, the practice that we do is to give caudal for post-operative analgesia or perioperative analgesia and general anesthesia. In very few premature individual babies, when we think that the spinal is going to be a better choice in that particular case, that we have given without any sedation or general anesthesia spinal. And as all of us know, the spinal acts for very short duration. So in case you think that in that particular situation, the general was totally contraindicated and you definitely want to adopt only regional techniques, what I would suggest is give a single dose spinal and thread caudally at catheter and locate it to the site where you desire to give the anesthesia, and at least wait for 40 to 50 minutes before you activate the caudal. So that is how it is being practiced, if at all. But I could not come across any guidelines for this. And I'm only afraid that we are talking about a situation when you want to give spinal immediately followed by a dose of caudal as well. I think that is going to be a very dangerous situation.
No, the reverse. He means the reverse. Epidural first, immediately the spinal, madam.
Okay. So that I have not done in my 36
But
plus
it's
years
a
of
practical
experience.
question. As you say, putting a catheter and just once by chance the spinal wears off, it could be a safer approach. Thank you very much, madam. Again, another question to you. It's here, I'm just checking.
Yeah.
This is a recent concept. It's there in pediatric practice already. Is parenteral caffeine effective in treating post-op apnea in preterm neonate?
Yes. There are a lot of literature stating that it is effective, and both oral and intravenous caffeine is available in India, and it is being routinely used in neonatal ICUs in the situation where they plan to wean a premature baby from the ventilator. But if I haven't done it myself, whenever I think that the child is going to be depressed, the child is shifted to the neonatal nursery where they start the caffeine infusion. The dose is 20 to 25 milligram per kg as a bolus dose. That is a OD dose, and subsequently you can reduce the dose to 10 to 15 milligram per kg body weight. Even the oral preparations are available, but I think it has to be done in NICU, because after weaning the baby from caffeine, it is mandatory that you monitor the baby at least for 48 hours. So everything has to be done in NICU only.
Yeah. Thanks, madam. So we have this evidence, and of course this is available. These are the brands and injections available in India. No, my mind went to, can we use it at post-surgery when we do neonatal procedures? So that's one area of application for us as anesthesiologists. Next to Dr. Sudhakar. So we have just around 8.5 minutes. We'll just keep it crisp and straightforward. Bilateral brachial plexus block is contraindicated according to me, and about two of them, Dr. Mukesh and Dr. Ganesh Tendulkar, many of them have this doubt, basic doubt. Can we do it on either side simultaneously? Otherwise, what should be the time interval? What is optimum duration between the blocks to avoid LA toxicity?
Shall we have a focused first question? If I am using ultrasound, if I am using axillary access, yes, I shall go ahead with. Next, if I am using again ultrasound infraclavicular approach, yes, I will be. But if I am going supraclavicular, I am cautious. I cannot say it's contraindicated. But in expert's hand, myself practicing ultrasound guided block for quite some time now, I am confident in restricting my dosage each side within the therapeutic dosage. It is not contraindicated at all. So if I am giving, of course, interscalene in bilateral both forearm is out of question. So I think I have answered your question.
Yes.
If I am using ultrasound, very cautious if supraclavicular, infraclavicular and axillary, no concerns at all. When it comes to the second question, well, we need to be aware if at all, let us say, you have only one surgeon operating one after another, you are also concerned about the toxicity. There are two major concerns why we are really debating about. One is the systemic toxicity, another is the phrenic nerve issues, which results into bilateral diaphragmatic palsy. So as far as systemic issue is concerned, if at all you want to do in the same sitting, surgeon wants to do after some time, and let us say you don't have ultrasound tool, I suggest we need to keep in mind the terminal elimination half-life. Let us say, for example, propionate you are using. This terminal half-life elimination approximately is about 6 hours. You need to use safely 6 hours. I think I answered the question.
So ultrasound is the key here, but if you are doing in a private practice without ultrasound, better be careful. You limit the dose and no need to do it simultaneously, and keep in mind the pharmacokinetics of the drug. Yes, sir. Thank you, sir. And Dr. Wayne Morris, question by Dr. Harihar Egde here. What qualities make one a perfectly professional anesthesiologist?
This is a really interesting question. The Royal College of Physicians and Surgeons of Canada have produced a document, the CanMeds document, So this was the 2015 Physician Competency Framework, and I'm sure many of you are familiar with this. It defines 7 roles for physicians: the medical expert, the communicator, collaborator, leader, health advocator, scholar, and professional. But I think the professional actually takes in a lot of those other roles. But they go on to talk in more detail about the professional, and they say that the professional has commitment to patients. We all know about that. Also commitment to society. So we all have this professional role to think about the public good. So think a bit wider than just our individual patients. Also commitment to the profession. So collegiality, mentorship, adhering to professional standards. And finally, very interestingly, commitment to self. So we had a workshop on emotional intelligence yesterday, and that's the sort of thing that they're talking about, that if we keep ourselves well, then we're going to be able to look after our patients and do our other duties better. So professionalism is a little bit more complicated, but I think those things like commitment to patient, society, profession, and self are really important parts to what makes us professional.
So quite a exhaustive requirement, but highly utopian. I don't think we can meet all those criteria, but we'll try our level best as the best anesthesiologists. Thanks a lot for collecting that information. Next to Dr. Anju, should anesthesiologists encourage gynecologists administering intramyometrial vasopressin during hysterectomies with obvious adverse effects which are possible? Are there any guidelines regarding the dosage?
There have been many adverse events reported with the use of intramyometrial vasopressin. So as an anesthesiologist, I would only like that my obstetrician or my gynecologist informs me when she is instilling and uses the correct dosage. There are no guidelines, but few of the studies and an editorial has come up which have suggested usage of very low doses, somewhere to limiting the dosages to 2 units and not going beyond 6 units, and also diluting it in a concentration so much so that your concentration is somewhere less than 1 unit per ml. So if you have 20 units, you would actually be diluting it to 200 or 400, and using lesser dosages. That can perhaps limit. But of course, as they instill into the myometrium, they have to be careful about avoiding an inadvertent intravascular injection, which is very difficult to catch up, especially when they're doing it with in a TLH with the laparoscopic instruments, and they tend to kind of aspirate. They hardly get to know whether they are in the vessel or not. So that's a catch up there. They really need to be careful when they instill.
Is it so widespread, the use now?
Not too widespread.
Hysteroscopic procedures.
Yeah, I think only myomectomies, and that too multiple myomectomies where they need cleared planes for dissection, they use it. Yeah.
Okay. So anyway, the caution is the word here, so we should be monitoring. Of course, we always monitor the hemodynamics, so that's the most important part. Thanks, madam. The last question would be about malignant hyperpyrexia. We know it is being frequently reported. In fact, now we have started rejecting reports being submitted to journal because it's being reported and even diagnosed properly nowadays in India. So, but still our colleagues have got question here. Is it rare in Indian population?
Okay.
Is it something to do with genetics?
The first thing is it is rare.
Yes.
Surprising is the last 15 years we have I came across at least 3 reports. Each one of them in over 15 years said this was the first reported case from India.
That's what it is.
2 from Delhi, 1 was from South here. So it is rare. But the problem is the second part. It is underreporting. There have been issues, there have been papers where it has been seen that people who migrated from India and gone to UK, they had malignant hyperthermia. So we know that it is not seen in India. We know that in our simulation programs, like maybe in New Zealand, Australia, we don't try to simulate malignant hyperthermia and check our residents with that. But it is there and it goes undocumented or unreported. Dr. Kumar Bellani, if you heard of him, we were trying to have a system with him and have something in Delhi for malignant hyperthermia, but it never worked on it. There is a report where people in Delhi have really done the caffeine halothane contracture test on a muscle biopsy. So it is not available commercially, but if you talk to a tertiary care pathology department, they could do it for you. And the last one, whether dental sodium is available to us in our country, yes it is. A firm from Mumbai is making it. However, it is something like what we were told yesterday, you have flumazenil, but let's hope you never need to use it. It's costly, it is available, I am not aware of anybody using it. Oral tablets were available. There is a report in IJ, I think, long back ago, where they've used it, but they never mentioned from where did they get oral dantrolene sodium. But now you have a concern in Bombay who markets it.
It's available, sir. I think
Yeah,
even
it's available.
stored in
I don't know the cost,
dantrolene.
it's available.
Yeah.
The problem is that you've got to keep them in your hospital. It's something like keeping intralipid for a last. You hope you never have to use it. So you'll have to convince your financial people that we need it,
Keep it,
and they will come up. A Stanford MBA would say you never used it, so you don't need it.
So thank you very much. You're on dot. Thanks to all our co-faculty here. For
Thanks to
question.
the
Thank you very much.
panelists and thanks to Dr. Bala Bhaskar. Just the last announcement about the prize winners. And to tell you that tomorrow morning we do one practice half an hour today, and tomorrow 7 o'clock we will continue that. So we would like to all of you to be here at 6:55. And the first place goes to Jesto Kurian. He asked 31 questions, and he is the topper in the number of questions. The second question, second prize goes to Mukesh and Ganesh Tendulkar together. And the third one goes to Dr. Renu from Kottayam. So they will be given the prizes tomorrow. Now we all get down to the bus.